Matterhorn has now checked both boxes in terms of improving event-free and overall survival, with the addition of durvalumab to perioperative FLOT. And the addition of durvalumab does not seem to significantly alter the toxicity profile of FLOT. I'm here to talk about immunotherapy in the perioperative setting for gastric and GE junction cancers in collaboration with GI Connect. So this is an increasingly important topic, and over the last several years, really dating back to 2019, we've seen the practice patterns converging on perioperative systemic chemotherapy as the preferred approach for resectable esophageal, gastroesophageal junction, and gastric cancers. And this has been supported by the FLOT4 trial, as well as more recently emphasized by the ESOPEC trial. So now we have two phase 3 trials that support the use of perioperative FLOT as a standard backbone for resectable esophageal, GE junction, and gastric cancers. Both of these trials improved overall survival, and the ESOPEC trial, which compared against chemoradiation, showed us the importance of active systemic therapy in reducing distant recurrences, which is really the drivers of overall survival and metastatic recurrence for our patient population. This set up an important scenario about where to go from FLOT, and now there are several phase 3 trials that have looked to add immunotherapy to the perioperative or adjuvant space. We actually have 4 trials, one of which we're awaiting the long-term event-free and overall survival results called Dante, but the 2 perioperative trials which are published are Keynote 585 and Matterhorn. Keynote 585 asked the question about adding pembrolizumab on top of doublet chemotherapy. There was also a small FLOT exploratory cohort. And Matterhorn asked the question with using FLOT as the chemotherapy backbone for everybody. In Keynote 585, there was an encouraging signal for the potential benefit of adding pembrolizumab on top of perioperative chemotherapy, but statistically this was a negative trial. To build on that, Matterhorn asked a similar question, except unified the chemotherapy backbone with FLOT for all patients. So everybody got FLOT as the backbone, and half of the patients got the addition of durvalumab or placebo. The primary endpoint was event-free survival, and the key secondary endpoint was overall survival. At ASCO in 2025, we saw that Matterhorn hit the primary endpoint for improvement of event-free survival. This was a statistically significant and arguably clinically meaningful improvement in event-free survival. And this is an important endpoint, both as an approvable endpoint, but also as a patient-centered endpoint. However, we still were eagerly awaiting the overall survival data. And just at ESMO, we saw the overall survival results from Matterhorn, which has now checked both boxes in terms of improving event-free and overall survival. There was a statistically significant improvement in overall survival with the addition of durvalumab to perioperative FLOT. We also need to look back at the safety data because FLOT is an active but can be toxic regimen. And so what we've seen is that the addition of durvalumab does not seem to significantly alter the toxicity profile of FLOT. The main toxicities for FLOT are GI, some nausea and diarrhea, as well as cytopenias, and these are not impacted by the addition of durvalumab to any significant degree. This sets us up with 2 very clinical questions. One is about the deployment of FLOT more broadly, and 2 is about surgery, as well as offering this to all patients. So Matterhorn also underscores the importance of surgical conversations for our patients because we need to know if this patient is anatomically resectable, i.e. can the tumor be physically removed with a high probability of R0 resection? And 2, is the patient medically fit for an operation? These are decisions that impact the use and choice of FLOT. However, in the Matterhorn trial, the vast majority of people were able to receive neoadjuvant FLOT plus durvalumab, and the vast majority, upwards of 90% of people, went to a surgical attempt. This suggests that FLOT is indeed feasible, and personally, I am quite liberal with dose reductions and adjustments to make our patients get through the neoadjuvant component because exposure to the active systemic therapy in the neoadjuvant setting is probably critical. The adjuvant settings represents another area where I'm quite liberal with dose reductions to get people through the adjuvant therapy. However, we do not have data to drop the adjuvant component of FLOT at this point. Another question is about giving the immunotherapy to all patients. We've seen the subgroup analyses for overall survival and event-free survival. And in my own assessment, the benefit is relatively consistent across the subgroups. Like other trials, we have seen a broader confidence interval for things like PD-L1 negative patients, diffuse type gastric cancer, and this remains an individual discussion with patients. However, in my own practice, I tend to offer this to all FLOT eligible patients. If you'd like more details, please feel free to download the slides that accompany this brief webinar.